بسم الله الرحمن الرحيم. السلام عليكم أولا. I would like to express deep thanks to Allah for His kindness, protection, and support during these hard days. And I'd like to thank Professor Dr. Muhammad Al-Ashhab and his team for inviting me to this wonderful and respectable course. During the coming minutes, I will share with you my prospects for diagnosis and management of pediatric ACL injuries, and I hope it will be fruitful and useful for everyone. I have no disclosures related to this presentation. Intended learning objectives of this presentation will be the magnitude of the problem. We have to think about pediatrics not just as a small entity. We know that we have to support diagnosis, treatment options, rehabilitation, finally, and I think the most important is prevention. When we consider ACL, the number of anterior cruciate ligament injuries reported in skeletally immature athletes has increased over the past 2 decades. The reason for this, in my opinion, is increased rates, growing number of children and adolescents participating in competitive sports, vigorous sports training at an earlier age, and the greater rate of diagnosis because of increased awareness in one hand, and in greater use of advanced medical imaging on the other hand. Pediatric ACL injuries occur to boys and girls, and as we know now, soccer is well popularized between both sexes. We are seeing now many kits and championships held in every part of the world for girls as boys. So it affects boys and girls. There is no racism. It can affect Africans, Asians, Americans, or races. Recent literature points to the high incidence of ACL injuries in skeletally immature athletes and show that these injuries account for about 35% of all new injuries in soccer players between the age of 5 and 8 years. And seeing this number, 18 years, many of well-known spectacular players in many clubs in the world is 16, 17, 18, and 19 years old. And you can think that these injuries in ACL is considered also as pediatric injuries. Another study reports an instance of ACL tears of 47% adolescents and 65% of adolescents who present with acute knee hemoarthrosis after trauma. In children, it's not easy to be missed because children have low threshold of pain, and after trauma, the pain, swelling, and inability to continue their match or training have to put to get attention of parents and trainers for possible ACL injury. Another study pointed that tibial eminence fractures are more common to occur, more accurately speaking, are more commonly to be diagnosed, because as we will see later, many ACL injuries in children are mid-substance tears, but they are partial injuries and go heal well with conservative treatments. But the most commonly diagnosed is the tibial eminence avulsion. Also, it has been noted with these fractures that there is variable degree of plastic deformation with permanent elongation of ACL fibers, which may cause residual clinical laxity despite anatomical reduction and healing of fracture. And putting in mind, we should remember that when refixing the tibial eminence, because many studies and many centers now are popularizing fixing this tibial eminence avulsion fracture in a deeper position than usual to compensate for the expected plastic deformation and expected ACL laxity later on. Which gender is more prone to it? Of course, females or girls, because of hormonal factors, because of anatomical differences, talking about the ACL shape and size, less fibers in the female group, narrower intercondylar notch in the female group, hip to knee alignment, Q angle, which is high in the female group. Also the biomechanics, cutting and landing techniques in the not well-trained females is different and may make them more prone to ACL injuries. Also ligamentous laxity, which is more common in girls than in boys, reflex action and strength imbalance, which is much higher in boys. Females have 4 to 6 higher incidence of all knee injuries, including ACL, patellar ligament injuries, collateral ligament injuries, and osteochondral injuries. Female have 2 to 8 higher falls of increased risk of ACL tears. Also, there is concerns about the sports-specific risks. Those types of sports with high pivoting like soccer, like team handball, basketball, of course, the professional level of activity and training have higher incidence than the recreational level of activity and training. There's weak evidence in skeletally immature patients with torn ACL that supports early surgical reconstruction. Most are low-strength studies lacking consistent evidence and does not allow to formulate recommendations or algorithms for management of such age group. Also, 20% of those kids or age group having ACL injuries are prone to have contralateral ACL injuries at a later time in their life. The parents and the trainers should have high index of suspicion. And if you suspect this, the first aid is to apply the PRICE protocol, which is the protection, rest, ice, compression, and elevation. The goal of this treatment is to reduce pain and swelling, and this should be applied and make the base for early rehabilitation. We recommend continuing the treatment PRICE protocol for at least the first 38 hours after the time of injury. This may include strapping techniques, may include various types of immobilizers or supports, and of course, delaying or preventing weight bearing and using crutches. When parents are faced with a decision regarding the optimal treatment for their children with ACL injury, they commonly ask you, if this is your child, what would you do? Foremost, and the answer is easy. We want the best surgeon to decide the best treatment that has the best outcome and the least probability of complication. But wow, this is not present. This is a matter of dreaming rather than reality. Interestingly, the paucity of high-level evidence of this area does not support the general consequences of pediatric, the general consensus of pediatric sports medicine experts, because of the pressure of parents, the pressure of clubs, and the pressure of media, especially in professional athletes. We have to think that many of these children are in the national teams of their countries, and pressure pushes you towards surgical intervention, although this is by the evidence. No randomized trials in the treatment of pediatric ACL injuries have been reported and perhaps may not be feasible. Functional, radiographic, and long-term outcomes of pediatric and adolescent ACL reconstruction remains unclear, with most of our clinical decision-making studies with level 4 and 5 evidence. And this is one of the surprising studies, which is popularized and published in 2019, knee pathology in young adults after pediatric anterior cruciate ligament injuries. And these are talking about 9 years follow-up, and its conclusion, we are the instance of new meniscal tears after ACL injuries is about 35%. This is also associated with other knee pathologies regarding the chondral and osteochondral injury. Primary active rehabilitation, close follow-up, and delayed surgery if needed may be viable and treatment options for treatment of pediatric ACL injuries. What are the common types of ACL tears in children? It may be cartilaginous avulsion, which is the more difficult to diagnose, bony avulsion, which is the most easy to diagnose, which is known also as tibial eminence fracture, mid-subscapularis tear, which is the most common statistically in the autopsy studies and MRI studies, and the partial tear. This varied spectrum of injuries can make accurate diagnosis difficult. Obstacles in this category of patients include the open physes, potential further growth should be considered, ligamentous laxity, especially in girls, and the compliance of the patient and the parents. Also, the compliance of the training and the trainers. The other important challenges in this age group are potential risks of recurrent instability secondary to chondral, meniscal injuries following non-operative treatment, and the risks associated with surgical treatment due to vulnerability of the open physes, growth plate, and also the very vulnerable cartilage surface, putting in mind that most instruments used in pediatric age group, which is available in most hospitals, are the same as used in adult age group. Further, if surgical treatment is chosen, there is controversy over the appropriate method of reconstruction as well as selection of graft material and fixation method. Proper with increased risk of fracture. The epidemiology, ACL tears fairly common and associated with hemorrhagosis, which is usually the first thing makes us suspecting the injury. The mechanism usually lateral blow to the leg, especially in cutting maneuvers and soccer activities. The treatment could be non-operative and operative, and in my opinion, all these pediatric age group should be started non-operatively and making the operative decision as a second step in treatment. Knee dislocation can occur in this age group, but this needs special different presentation and have different consideration, although there is common than adult age group. And this is the classification of knee dislocations, which is higher trauma and not commonly seen in sports injuries. It's rather seen in road traffic accidents. Treatment of knee dislocation includes reduction with neurovascular examination as in adults, before and after, knee immobilization and extension, operation if there is an unstable knee with ligamentous injury, external fixation for stability of vascular repair if required. The imaging, X-ray, which could be very deceiving in children, especially in cartilaginous avulsion. MRI is the gold standard. Ultrasound, if the MRI is not available or expensive or in skeletal immature imaging, the X-ray should be AB, lateral, notch, and merchant view. We should examine the patellar dislocation, as Dr. Hisham said, physeal maturity, open, narrowed, or closed physes, phalangeal injuries with stress views, which could be misdiagnosed or missed during consultation by the radiologist and the surgeon for the primary injury of the ACL. The general indication for ACL surgery are patients' inability to participate when he chosen sports, and the word chosen sports is very precise because not every children and not every parent is adapted and can accept changing the type of sports that their child is practicing, participating, especially if they have spent many years in this sports or if the child is a member of the national team. Instability that affects activities of daily living, and associated treatable meniscal tears or a knee injury with multiple torn ligaments. Pediatric ACL, we can consider repair, whether tibial or femoral avulsion, whether repair or augmented repair with PRP or stem cells. Enhancement of the growth, if we consider reconstruction, we have the transphyseal option, partial transphyseal option, and physeal sparing techniques. What are the rebates in the pediatric age group? The timing of surgery, delayed versus early, and most literature now supports delaying surgery for a few weeks, up to 6 weeks, and in some studies up to 12 weeks, giving enough time for conservative rehabilitation and evaluation. Graft choice, no rule for patellar tendon bone in this age group. Repair versus reconstruction. If we are talking about repair in adult age group in these days, so repair is much more supported the pediatric age group, putting higher potentiality of healing. Augmented repair, using ACL internal brace, material or fixation tools that to be used. Allograft should be completely avoided if at all possible, due to the unacceptable failure rates noted in young active patients and the potential risk of disease transmission in such age group. Most orthopedic surgeons agree that the optimal surgical timing of ACL reconstruction is after full range of knee motion has been achieved, unless in the setting of tibial eminence fracture or associated bucket handle meniscal tear and multiple ligamentous injury. This is what we mean by reconstruction. It could be physeal sparing, it could be partial transphyseal, it could be a complete transphyseal technique. These are the different techniques, and these are the different fixation methods. The decision to perform the type and the reconstruction and type of the graft choice should be determined by the remaining growth potential according to Tanner, and determined by Tanner staging and determination of skeletal age by hand radiographs, also now by MRI. Careful usage fixation technique of internal bracing. This is algorithmic management of pediatric ACL injury. If we have complete symptomatic ACL tear in skeletally immature patients, we have to check for maturity assessment and skeletal age determination by Tanner staging, hand radiograph, and MRI. If he is very young, prepubescent, male below 12 years, female below 11 years, we will go for patients' informed decision together with the parents. We have to try non-surgical treatments, activity modification if at all possible, closed chain rehabilitation. If the child complains of recurrent instability on resuming thinning, we have to go for physeal sparing reconstruction. On the other hand, young adolescents with growth remaining, Tanner stage 3 or 4, males 13 to 16, females 12 to 15, we can try partial transphyseal with over-the-top femoral tunnel technique, or transphyseal with hamstring autograft and metaphyseal fixation. Older adolescents and pre-adolescents, male above 15, females above 14, can be treated as adults with reconstruction with interference screw fixation, patellar tendon, or hamstring autograft. In contrary to adults, the graft here is maximum 8 centimeters in diameter. The length is 55 to 65 millimeters in length. Femoral side tensioning button is preferred. Tibial side tensioning loop is used. We have to mark sutures at 20-25, and we have at all expenses to avoid over tightening of the graft to avoid premature epiphyseal closure and arrest. Going for the physeal sparing or modified Macintosh, which is described very early in 2005, the irritable band harvested proximally and passed over the top position, then under the meniscal coronary ligament. In this study, 44 patients, Tanner 1 and 2 revision only at 5 to 8 years, 98% normal or knee normal Lachman test, 100% normal or knee normal pivot. The IKDC is 96.7, no growth disturbance, but the and early onset arthritis is still there. Completely avoiding the physis in the very young age group, Tanner 1 and 2, by either going over the top, then under the intermeniscal ligament, then taking anteriorly and fixing the graft to the metaphysis or proximal diaphysis, using either screws, washers, staples, or whatever you want. In contrast, in the right part to the partial transphyseal, which can pass in the tibia, keeping the part in the femur still extraphyseal or physeal sparing. The slide, the picture in the very right of the slide, going all the tunnel through the proximal part of the epiphysis. The second one is returning back outside the epiphysis, going back to the proximal metaphysis or diaphysis. What is the advantage of this technique? Sparing the physis, sparing the SGS, more constraint, more sense of security. The disadvantages are larger wounds, risk of meniscal or cartilage injury, tight knee when we are over enthusiastic to type the graft. All epiphyseal techniques, we can fix the graft by transosseous sutures. We can fix it as we see here. The tunnel is transverse in the lower field, and the graft is only in the proximal epiphysis of the tibia or just below the coronary ligament. Technique, we save this and we graft transosseous or a screw or a washer. Complete epiphyseal technique, this is the same. Here is 6 endobutton lower femur and another endobutton in the proximal epithelial epiphysis. The advantage of all epiphyseal technique is placed within the native and the modified Macintosh technique, avoid potential growth disturbance related to transphyseal drilling, and avoid potential growth disturbances by graft or the fixation technique. Epiphyseal. And this is the cannula used to avoid buckling of sutures when we are going under the intermeniscal ligaments. And this is the graft harvesting. We can use in the femoral side the outside in technique that is another used in PCL reconstruction, and we can use also the image intensifier. This is the BCL guide, which can be used to get the long tunnel in the epiphysis, avoiding the physis, and X-ray control is a must. Here we can use what's known as the retrograde drilling by flip cut, and we can apply this for the very young children with very successful results, avoid cartilage injury, and more accurate placement of the tunnels, making the tunnel in the femur almost transverse. This is the tibial socket preparation. And this is the femoral side preparation with protection of the, and I prepare here to finish the last 1 or 2 centimeters of the drill in the tibia and the femur using either manual reaming or hand drill, or just disconnecting the Jacob connection of the drill and using it manually under very controlled power and very gradual technique to avoid harming the physis and to avoid harming the intra-articular bar of the cartilage. This is the post-operative MRI picture of the tunnel. When we go for the partial repair for the complete epiphyseal technique, we can fix by suture anchor, we can use transosseous sutures, and we can also use cannulated screws. The preferred technique and the most trustful technique for fixation is the transosseous sutures, because the purchase of the anchor or the cannulated screw in the proximal tibial epiphysis is doubtful with the follow-up, because this part is mostly cartilaginous, and what you can get the sensation of good purchase now can be later on with the start of rehabilitation, a weaker or poorer fixation. Partial repair with complete epiphyseal technique in the femoral tibial side can be used, as I said before, suture anchor, cannulated screw, and transosseous suture. We can use primary repair or augmented repair, or supporting this repair with internal brace. Transphyseal with metaphyseal fixation, avoiding the tuberosity. The problem with this technique is usually that you have to go for another operation to remove this small plate later on, because neither the child nor his parents will accept leaving this metal in X-ray for a long time, and also to avoid complication of delayed hardware problems. Maximal violation of the physis during drilling allowed is 5 to 10% of the risk of the physis near the center, and less than 5% in the periphery. The central part is the site of the drill, and the peripheral part is the site of the bottom. Therefore, tibial drill bit should be less than 8, and this is in reverse to the adults which you don't usually accept a drill bit of less than 8. The most encounter type in our practice, although not the most frequently occurring, is tibial eminence avulsion fracture. This is the plain X-ray classification. Grade 1 is non-displaced, grade 2 partially displaced, and grade 3 is completely displaced. But now it's largely replaced by MRI classification, which is 5 types. Type 1, non-displaced with complete cartilage intact. Type 2, minimally displaced with partial cartilage injury. Type 3A, displaced with posterior intact hinge. Type 3B, displaced and rotated. And type 4, completely displaced and proximally migrated. The cartilaginous avulsion is the most difficult part to diagnose because there is no X-ray evidence of the injury, and can be missed even for the radiologist if he is not expert and trained and oriented by such type of injury. Also, we tackle the injury. We take transosseous sutures with the ACL and with the cartilaginous part using scorpion or suture lasso or whatever technique you want. And then we pass these sutures by transosseous sutures and tie them out over a bony bridge, a screw, a washer, or a staple. This is another method of fixation using cannulated screw. But as I said before, the problem with cannulated screw is that the purchase you get at the time of the operation is not the same maintained later on with follow-up and rehabilitation. And so you get later or delayed plastic deformation. The unique and important consideration in pediatric patients are the effects of tunnel size and tunnel drill angle in the physeal. The risk of physeal arrest increases when the physeal damage area affected by the drill is increased more than 7 to 9%. Also, the injury and the risk is increased using all motor or power drill, using hand drill or manual drilling. And also the risk of arrest increases when the tunnel drill angle becomes more oblique. So try to keep it as vertical as possible to decrease the surface area affected from the physeal. Graft tension is also an important determination of physeal damage. The higher the tension, the risk of physeal injury. Allograft usage is also shown to increase the rupture rate. And tibial eminence avulsion, as I said before, should go down at a deeper part to compensate for the expected plastic deformation later. Tips for construction. Literature suggests that small diameter tunnels with soft tissue autograft, vertical tunnel placement, avoid implant or hardware fixation across the lateral distal femoral physis, and less graft tensioning minimizes the gross disturbances. ACL graft increases mainly in length, not during growth. That's why we have tendency to delay the reconstruction as much as we can and as much the child and his parents can accept. ACL tibial angle becomes significantly larger with increasing age during the skeletal growth, and ACL rupture is higher than in adults. On the other hand, rate of significant growth disturbance is very low during applying these techniques. What's the near future? There is a Mayo Clinic project started 2019 using injection of PRP with torn ACL together with augmentation or repair. The hypothesis is bridging of the wound side with ACL healing and a stable bridge with brace or something like this to resist the site degradation and maintain the stability to stimulate cell ingrowth and proliferation, combined with suture for bio-enhanced repair. The hypothesis testing in vivo, large animal study so far in 30 pigs, bilateral ACL transection, one side treated with suture with PRP, contrast treated with suture alone, outcome MRI and biomechanical and surgical studies, and the results are so far favorable and promising. Adding PRP did not make a difference. Equal yield loads, equal inner stiffness, equal knee laxity, but with protection for possible knee injuries and shortening the rehabilitation time. Fibrin degradation in the joint could be decreased by putting this in the right technique, and applying scaffolds. How to prevent BRB from getting washed away? Using fibrin-based BRB, leading a carrier to make it resistant to plasmin dissolution in synovial fluid. Collagen when mixed with fibrin in BRB forms a copolymer that is resistant to degradation by plasmin. Collagen activates platelets also. The carrier for bioactive agents includes MIACH scaffolds. Tried multiple commercial collagens, but none met these criteria. That's why it is still under study. This is the future. Computer-assisted ACL reconstruction. The advantage of this is more accurate tunnel placement, decrease the need for intraoperative imaging for the child and for the surgeon. Rehabilitation, where bearing period after ACL injury is typically delayed in children as compared to adults. Neuromuscular adaptation that occurs in young athletes following the period of peak growth adults with ACL. Simply stating, delaying the rehabilitation and don't be worried about possible quadriceps atrophy. Rehabilitation after ACL reconstruction needs to be individualized for each child, patient's functional and sports ability, months, and also tailored to the particular surgical procedure used and the particular fixation is applied. Early protection with pediatric knee braces is very important, especially this age group is very uncompliant. In general, a graduated rehabilitation program, usually a 5-phase program as compared to 4-phase program in adults, emphasizing full extension, immediate bearing with brace and crutches, active range of motion, strengthening of the quadriceps and hamstring, hip, and core can be started in 6 weeks after surgery. Progressive rehabilitation during the first 3 months after surgery includes range of motion, exercises, patellar mobilization, proprioceptive exercises, endurance training, chain strengthening exercises, straight leg jogging, plyometric exercises. Sport-specific exercises are added at 4 to 6 months and return to sports in children not before 8 to 9 months. These are some types of rehabilitation protocols applied in the 3rd and 4th stage of rehabilitation. Prevention, the development of pediatric athletes' neuromuscular control is shown to be a modifiable risk factor for developing an ACL tear. There are 2 recognized preventable programs. One is applied by the FIFA, and the other is the Prevention Injury and Enhancement Program from Santa Monica, which are designed to improve the athlete's neuromuscular control and in turn prevent ACL injuries, especially in girls and especially in basketball. This is the evidence-based practice guideline for prevention of anterior cruciate ligament injuries in young female athletes in a systematic review. In conclusion, various programs competent of ACL neuromuscular control and neuromuscular training are associated with a reduction of injury. They recommend that ACL neuromuscular training program targets young athletes and use trained implementation who appropriate lower body strength in the exercise and focus specifically on landings and stabilizing exercises, jumping and hold, drop and land throughout the sports season. Coaches, athletes, parents, practitioners can use developed checklists to gain insight into the quality of their current ACL neuromuscular training practice, as well as to inform modification or development of future ACL neuromuscular training. For young girls, the best window of opportunity for ACL injury risk reduction may be during early puberty and early pubertal maturation, at or just before girls' neuromuscular risk factors starts to become evident and ACL injury rates in girls dramatically increase. Pay attention and keep concentration, learn to land, jump, and fall safely, strengthen leg and thigh muscles, neuromuscular training programs. In the clinical setting, we can use a simple drop vertical jump test to help us identifying athletes at higher risk of ACL injury based on their landing mechanics, and then recommended these individuals to designate therapists and trainers to work to their neuromuscular control. These are some exercises to prevent ACL tears in girls, which are more vulnerable to this type of injury. Very important is to correct the wrong valgus angle in landing and running in girls. This in the picture in the left side before hip abduction training, and the same girl after training of the pelvic muscle and the abductors. Also, the picture in the right side, jumping and landing on one leg. One on the right is not trained, and one in the left is trained. Also, semi-squatting and squatting training, knee position during running and during landing on one leg, especially in basketball. This is the slide I gave before. What's the recommendation in 2019? The recommendation is to allow primary active rehabilitation, close follow-up, delaying surgery if needed, except if associated injury or study preparation and follow-up. They advocated that yearly surgery and meniscal repair of those with additional meniscal injuries that warrant surgery for children without additional injuries warranting surgery. They suggest primary active rehabilitation, close follow-up, with the option of later surgery, the same study. Increased time from injury to surgery was not significantly associated with additional injuries as evidenced by MRI, and as I said before, not associated with significant quadriceps weakening. The International Olympic Committee consensus statement on pain management that's elicited in 2017 and revised in 2019. These are very aspects that's overlooked: the psychological intervention for the children, sleep and nutrition intervention for the children, pharmacological pain management strategies in elite athletes and the national teams. And this is available on the internet. In conclusion, acute cruciate ligament injuries in pediatric patients are increasingly common. They can present as tibial eminence fracture, partial ACL injuries, complete ACL tears. MRI can be valuable for diagnosis of ACL tears and associated meniscal and chondral injuries in pediatric age group whose physical examination is difficult because of pain, swelling, hemoarthrosis, and lack of cooperation. An ACL tear in a pediatric patient is not surgical emergency. Multiple discussion with the patient, with the trainer, and with the child are done with respect to athlete's goals, expectations, type of sports to go to after rehabilitation, and to reduce the family possible treatment options. The patient's skeletal age measured by anteroposterior radiographs of the left hand and wrist stage are important tools in planning the ideal surgical treatment techniques, the graft choice, the fixation choice. Surgical treatment has led to improved results in those with displaced eminence fracture, partial tear with positive pivot shift under anesthesia, and complete ACL tear. Technique for ACL reconstruction is typically based on the status of phases and variations of the treatment algorithm guided by the age. Neuromuscular training is very important, and thank you for your attention. Please stay safe.
Thank you so much, Professor Wael Nassar, for this interesting talk in this interesting topic. هو يعني بصراحة topic رائع دكتور وائل بيه، فإحنا بنشكر حضرتك شكر جزيل، وأنا شايف أستاذنا الدكتور هشام بيه القاضي رجع تاني معانا، we are very happy with both of you, sir. We are waiting for questions for Professor Wael Nassar. The first question, Dr. Wael, from Dr. Magid Sami, Professor Dr. Magid Sami. Instance of re-tear after pediatric ACL. Does the graft diameter increases with growth?
شكرا. Thank you, Dr. Magid. No, unfortunately, the graft diameter doesn't increase with growth, only the length. And this is the problem of early intervention. That's why the most surgical protocols now recommend for delaying intervention as much as we can. The second part of the question, the percentage of free tear. In some studies, it's up to 40%. And part of this is due to anatomical variations in the intercondylar notch. And this is also the basis that most or many of these children, when have ACL injury in one side, usually have ACL injury on the other side later on in life. So the possibility of re-tear in some studies 37 to 40%, other studies up to 60%.
Thank you, sir. Any other questions to Dr. Wael? We have another question. So regarding transvisial with metaphyseal fixation, why to avoid tuberosity? Is it due to bony immaturity? From Dr. Sulaiman Yunus.
The tuberosity, there is the apophysis, as we know. We don't want this child to go into problems with the growth of the extensor mechanism, as Dr. Hisham said. We don't know this child to go into Osgood-Schlatter's disease. We don't know this part to be weakened so that it can be got avulsion injuries with resisted extension activities. That's why we make our fixation distal to this part.
Yes, sir. Any other questions from the audience?
كنت عايز اسال الدكتور هشام بعد اذن حضرتك بالنسبه للكوادريسبس رابتشر. انا الحقيقه فعلا واجهني.
دكتور هشام بيه ودكتور هشام ميوتد. دكتور هشام بيه.
تمام، هو كده معانا. فانا سؤالي لحضرتك، انا الحقيقه جزء كبير من الناس دي استخدمت لهم السوتشر انكرز، الار سي انكرز. ده اسرع طبعا في السيرجيكال تكنيك واصغر في الجرح، والحقيقه الفولو اب بتاعهم كان بالنسبه لي معقول جدا، ريزنبل. فانا بسال خلال حضرتك مقارنه السوتشر انكر بالترانس اوسيس سوتشرز.
For which category?
الكوادريسبس رابتشر from the proximal bore of the patella.
proximal bore of the، يعني هو صراحة احنا بننظر ليها from the economic point of view. فأنا لو عملت two holes with bony bridge sufficient enough to avoid cutting through ال two exit holes، يعني ال one suture the thread will pass through two tunnels equal to two suture or two anchors. Okay. And we apply the same technique in rotator cuff for supraspinatus avulsion and for flexor hallucis longus transfer to augment the tendo-Achilles rupture. And in any soft bone, even if you have an MCL avulsion from the medial femoral condyle, we apply the same technique. Once I am in an epiphyseal area, the AC bond number 5 has a very strong rigid needle that you can pass through easily through the soft metaphyseal bone. And if you have a better bone stock that would not allow the passage of the needle, you may apply a very small awl, for example, a K-wire, to start as a starter to drill the cortex. And then you pass the needle. After passage of the needle of one single suture, you may have the efficacy of two suture or two anchors.
السؤال الثاني، هل حضرتك في العينين دول باعتبار ان الكوادريسبس تيشو هنا بيبقى وحش عاده، do you augment this part with
yes, I augment with gracilis or sometimes with semitendinosis. The same like I am doing banner suture, for example, or crisscross. I pass the gracilis or the semitendinosis across the soft tissue part of the quadriceps tendon, and then passing it through two longitudinal drill holes in through the patella. But the difficulty in the quadriceps that you cannot protect because you have no more proximal bone like the patella and the tibial tuberosity when you are going to repair the patellar tendon. So you have to modify your post-operative rehabilitation for longer time, avoid vigorous bending of the knee, and use a brace for a long time, maybe 12 weeks at least.
هو the advantage on the other hand يا دكتور هشام ان الكوادريسبس هنا فليشي ماسكولار، فاليلد بتاعها بيقلل الاسترس. بتقلل الاسترس.
It yields with time. But you should make sure of complete healing because before you go to increase flexion range of motion beyond 90. You shouldn't go beyond 90 at least after 10 weeks, for example, 2.5 months, graduated.
Okay. Thank you, sir.
And you should have a very meticulous cooperative patient. He is responsible for success of such surgery.
Sure.
We have a question to Professor هشام القاضي لان حضرتك احنا ما لحقناش نقول الكويستشن ده
أيوة فاهم.
كان النت فصل. فهو دكتور رامي شريف, bilateral tibial tendons mid substance rupture. How would you judge the correct length of the repair? Would you use Caton Deschamps or another guide, sir?
I have introduced the criteria for the judgment of the proper tension on the operative table. First, you should have a slack repair, which is difficult, of course. If you have an old tear, you are anxious to make it tight. By nature, you are going to make it tight. But the normal tendon, if you are going to do, for example, an open wedge or high tibial osteotomy or closed wedge, you can see the slackness of the patellar tendon. In full extension of the knee, while the patient is anesthetized, the patellar tendon is quite lax. And you may pass a human underneath and you can see the slackness of the patellar tendon while the patient is anesthetized. So the first is you should have a slack repair, not a very tight. Second, you may have a lateral intraoperative lateral view, and after you repair, because before you finalize the fixation, you should have the tip of the patella opposite to the Blumenstadt line at the position of around 40 degrees in lateral view. The second one, third is very easy, is the Unsol Salvati index. Measure the length of the patella, and you should have an equal length of the patellar tendon after repair. Doesn't matter the patient has a unilateral side or bilateral. This is the criteria of normal patellar height and normal tension of the patellar tendon. But fortunately, we are dealing with collagen. You know, by nature, this collagen is a retractile soft tissue. It is not elastic like rubber, but for example, when you are going to treat a long-standing varus knee with lax lateral structures, not injured, but the lateral structures is attenuated and lengthened with time for, say, for example, 10 years of varus knee with a patient having a medial compartment osteoarthritis. So you have a lateral lax structures. After correction of the varus knee with valgus, high tibial osteotomy, whatever the type, closed wedge or open wedge, after 6 weeks, you have a recoil of the collagen on the lateral side that was previously quite lax and elongated. And the same criteria for the current concepts, they attack the difference between closed and open wedge high tibial osteotomy. They mentioned that open wedge high tibial osteotomy tightens the patella downwards, and the closed wedge high tibial osteotomy relaxes the patellar tendon and they cause some sort of patella alta. But 2 years later, they correct this mark, and they correct this doesn't work because collagen will retract to its normal original length. There is no patella baha after open wedge high tibial osteotomy, and there is no patella alta after closed wedge osteotomy, because we are dealing with collagen that it stretched with time and it regains its normal length after some time. It recoils. So a minimum difference in about 5 millimeters in quadriceps tendon or patellar tendon doesn't make a difference after long-term follow-up, because tissues, like Professor Wael said, it goes with time and it corrects itself to the original length, like the quadriceps tendon. The quadriceps tendon exertional length is about 40 centimeters from the patella to the origin of the rectus femoris, the reflected head and straight head. And the patellar tendon is extremely short, about 4 centimeters, for example. But when you have a long tendon and a long excursion of the muscle, it will cover a minimum difference in length. The same technique and the same idea when you are using hamstring tendon, for example, average length 8 centimeters in ACL reconstruction, and a bone tendon, patellar bone tendon bone with a collagen exertion area about average 3.5 centimeters or 4 centimeters. So the exertion length of recoil of collagen in the hamstring differs completely from the patellar bone tendon bone. So we are dealing with collagen, which is forgiving. We are not treating bone or concrete or something solid tissue. We are treating collagen, which will yield with time, and it will regain its normal, near normal original length with repetitive guided post-operative rehabilitation programs.
شكرا جزيلا استاذنا الدكتور هشام بيه على التوضيح الجميل ده يا فندم. شكرا يا فندم. Any other questions? Any other questions? Okay, now we come to the end. بنشكر اساتذتنا الافاضل استاذ دكتور هشام بيه القاضي واستاذنا واخي الحبيب استاذ دكتور وائل بيه نصار على تشريفهم لنا اليوم في التيتشنج كورس. يعني احنا شرفنا وسعدنا بتواجد حضراتكم معانا يا فندم، ونأمل برضو ان حضراتكم تشرفونا في باقي الكورس، يعني لو وقت حضراتكم يسمح ب